I think you've basically covered my essential credentials. And I think in terms of our discussion tonight, I think a very important component is the fact that I myself am also a migraineur and have been a migraine sufferer for my entire life. In fact, ever since I can remember. And it's very strange when I think back and I remember back as far as I can go. I always found it normal that you get these nasty headaches, usually when you didn't sleep well or slept too much, and other factors which I can't account for. But I had always thought it was normal that one had these headaches. And eventually I understood as I grew up, because I saw my mom had very, very severe headaches, which obviously turned out to be migraine, that eventually I understood that I had inherited whatever it was that one inherits and gets migraine, and I was carrying the migraine predisposition, which I carried. And the other thing was, even into my teen years and my student years, as a medical student, I used to take it as quite normal if we really used to get drunk on a Friday night or Saturday night, that you would write off the next day, and that was normal. That was called a bad hangover. But after a while, I realized that I was the only one that was getting such severe hangovers. And obviously, this was, again, a manifestation of my migraines. And so ever since I can remember, I've been afflicted with these real nasty headache, stroke, migraines. So I'll make reference to it as we go along, and my insights, obviously, I've had to probe all available interventions over time, initially as a medical student, then as a medical graduate, and then went into the neuro field and obviously sought very differently. I was now going to be a referral area for migraines and severe headaches. And so it took on another spin, and I went into it in a lot more detail, again, both for myself and for those in our social circle who suffer from migraines, and obviously in the practice itself. Just some really amazing figures, and these I just read up recently. I didn't realize, in fact, that there are 1 billion migraine sufferers in the world. 1 billion. 1/8 of the world's population suffer from migraines. It is quite a mind-blowing concept that makes it the 3rd most common illness in the world. It really is something that I've never even reflected on, and to know intimately and with great knowledge and understanding the degree of incapacitation that this condition causes. This must result in an enormous amount of downtime and lost productivity in the world. And obviously, this is a real big problem, and something which even I didn't fully appreciate. So that really was an amazing figure. Commonly known is that it is much more common in women. In fact, it's 3 times more common in women. Some figures put it up to 80% of migraineurs are women. And while we're talking about women, one of the important considerations are obviously the hormonal milieu. The hormonal milieu has a very significant part to play in migraines, and usually premenstrual. And for a similar reason, we see amongst women this favorable outcome when they reach menopause. There is some kind of reward at menopause. Many actually improve significantly in terms of the severity of their migraines. So that's the background. It is not necessarily a headache. It has the atypical type of migraine, which I'll describe shortly, which may or may not be followed by the headache or the migraine component. In terms of the migraines, there are a group of conditions which are all, I just want to see if I can clear this off my, there we go. That's better. There's just some window open up on my screen. So there are a group of conditions which are all very closely related, all slightly different causes, but may often occur in the same person. So there is the classical migraine, then there's the atypical migraine, then there are cluster headaches, then there's something called chronic paroxysmal hemicrania, CPH, which is a big problem, but a lot less common. And then hemicrania continuans. So we have a group of conditions, all vascular. Actually, hemicrania continuans is the one that's not really vascular. The chronic paroxysmal hemicrania is the one that is vascular. And people may have one or more of these in different forms at different times. And we need to be aware that we may have different syndromes. The classical migraine is the one which starts off with almost like a dullness, a numbness described almost. And then that's the so-called vasoconstrictive phase. And then as the blood vessels open, it becomes a full-blown migraine or headache. And commonly is one-sided, unilateral, but it can be both-sided. And that's the classical migraine. Then you get the atypical migraine, which is the one that has the flashing lights, usually on one side, or numbness of the face, or both, or numbness of the hand. And if it is, and I always know this from myself, I usually get typical migraines, but once or twice a year we'll get the atypical migraine. And the atypical migraine will be the flashing lights. And I know that from a neurological point of view, that if my flashing lights are on the right-hand side, that means the left side of my brain is involved in the process, which I'll describe shortly. Then I know there's a chance that I might lose my expressive speech because that's very nearby the left side, close to vision. And this is the atypical migraine. The cluster headaches are traditionally in the early hours of the morning and are very severe, usually unilateral, one-sided, usually associated with reddening of the eye and blocking of the nose. And migraineurs may suffer from clusters from time to time. CPH, again, one-sided, usually triggered at the base of the skull, between the skull and the neck. One-sided, can be very severe and can last anything from minutes to hours, and sometimes even to a full day. And it is well known that it responds well to one of the anti-inflammatories, which we call orthorexin, and I'm not sure what you may call it orthorexin in your part of the world as well. So much so that it's almost called orthorexin migraines or orthorexin headaches. It's so specific for that type of medication. So this is a subject that can easily get out of hand. So we're going to have to go through this very logically and methodically. And so I just want to talk a little bit about what we know about the physiology or the pathology that gives rise to this phenomenon of the migraine. Again, there's a lot written, and in medicine, we know that the more that's written about something, the less that is known about it. And this is one of those problems. There are big textbooks. The biggest textbooks are the ones on migraines. And migraine, I'm afraid, is something that still eluded us in many ways to this day. And it's still left it in the realm of the art to control it rather than the science, although the science is catching up. But there's still a lot of gaps that we need to fill in. So we have this strange phenomenon in the neurochemistry that precedes the development of what will become the full-blown migraine. And here I'm going to talk about the classical type of process of events that leads to the classical migraine. So we know that for some strange reason, again, still lots of work going on to that, we're talking about two primary neurotransmitters. The one is serotonin and the other one is dopamine. And for some reason, dopamine just has a precipitous drop. We don't understand why. It seems to drop at about the time that we feel this dullness. People describe it as a discomfort originating in the base of the skull, radiating up into the head. But it seems to coincide with those type of symptoms. And with it is a rise in dopamine. And often we see in neurotransmitters this inverse relationship with serotonin and dopamine. And it's that precipitous drop then that gives rise to this constriction of the blood vessels initially, followed by an overdilatation. The overdilatation, this massive opening up of the blood vessels in the lining of the brain, called the meninges, is the thing that's associated with the actual headache, the blinder of a headache. But we need to elaborate on that a little bit more, and that is that at about the time that this massive dilatation of the blood vessels occurs, we have an inflammatory process which takes place next to those blood vessels in the meninges. And it's served by the nerve endings of the trigeminal nerve, which is the fifth cranial nerve, which innervates the meninges and which comes right up against the blood vessels. And what we actually see to complete the picture is that there is this neurotransmitter change, there is this vasoconstriction, the spasm of the blood vessels, followed by this inflammatory activity in the proximity to the blood vessels at the nerve endings, the sensory nerve endings of the trigeminal nerve. It seems to release a vasoactive type of chemical which causes the blood vessels to dilate, and in this way initiates a local inflammatory process. So we can already see the potential for intervention by looking at that cascade of chemical events. So the first thing that we need to take into account, and which we would look at for possible intervention, is that precipitous drop in serotonin is an important one. The excessive rise in dopamine is another potential intervention. And then, of course, the obvious one is the inflammatory process. And here we would look to the range of anti-inflammatories. So that's really what is happening physiologically that we know of. There's obviously a lot of other things taking place. If we go into the subcellular level, then we're looking at a chemical, CGRP, and CGRP is a mediator of many things, and it has a receptor. And it seems to become very active also in the same process. And much more recently, the CGRP has become a target for monoclonal antibody treatment, one of which is erenumab. I never pronounce these well. And they've got many different names all over the place. Anything that ends in umab is a monoclonal antibody directed at a specific structure. So that's basically laying out the scenario, the pathophysiology, if you want to call it, that gives rise to the condition. So just before one goes into the array of interventions, I think we also need to look at lifestyle factors, which also predispose and which are also going to need to be taken into account in terms of the intervention. for me, one of the most important lifestyle considerations, and this actually applies very much to myself, is that of sleep disturbance. And I found, in fact, that in myself, and in fact, I would say the vast majority of my patients, sleep disturbance, whether it be interrupted, too little, too much, abnormal for various reasons, such as airway obstruction type problems, causing apneic periods. All these phenomena in a person predisposed to migraine would often predispose and actually precipitate the migraine. So sleep seems to be a very, very important predisposition. Abnormalities of sleep seems to be a very important predisposition. And I know in myself that it's been like that. If I haven't slept enough, usually the next day has been okay, but the day after, for some strange reason, that's after I've had a real deep sleep after being sleep deprived the night before, is the day that I get my migraine. And so I had this, it became a regularly known problem in my old work unit in the hospital, and that was the day that we worked right through wasn't the problem, but the next day they knew that Weinberg was going to come down with a real blinder of a migraine. It was always that second day. And I find that today as well. The next very important consideration is this concept of stress. And what happens with stress is obviously stress is associated with adrenaline and cortisol secretion. And it's the adrenaline that pushes up your blood pressure, which is important, but it also causes vasoconstriction, the spasm of the blood vessels. And in my particular case, that's very important. And that could be a predisposition, because what happens with me is, and this might be illustrative of a lot of individuals, and that is on my surgery day, which is a very stressful day, invariably I'm fine. I've usually got up very early, and it's a very stress and action-packed type of day. The nature of the surgery that I do is highly stressful. I usually finish off the day without a problem, but the early hours of the next morning, I get my blinder of a migraine, almost to the point that I have my medication waiting for me next to my bed. I literally have to swallow it because it's almost like clockwork. Around about 4 in the morning, 4 a.m., the following morning after a very stressful day, I'm now facing the equivalent of the overdilatation of the blood vessels, probably reflecting the day's vasoconstriction of the stress of the day before, which is a very interesting phenomenon. The other thing is that if one is in, and I can only call it the migraine phase, if we're in the migraine phase, and us migraineurs know when we're in a migraine phase, we're in a migraine period, and we know we're predisposed to it, we can just begin to feel it bubbling under the surface. If we experience a really stressful situation or an anxiety-provoking situation or an anger situation, anything that pushes up our blood pressure when we are in our migraine phase may well precipitate the full-blown catastrophe. You're going to get your full-on vasodilatation, and you're now in your migraine situation. Often find that if one's really had a bad migraine, we remain in that migraine phase for a couple of days. And you know that it is a vasodilatation pathology, because if you're in that post-migraine phase and you're not fully out of it, you don't have a roaring migraine, but you feel the remnants of the migraine. When you cough or sneeze, you feel that generalized sudden tenderness, I'll only call it a tenderness, throughout your head. And that's a reminder that the blood vessels are still potentially overdilated. And therein lies the problem. You're not really out of the woods yet. So these are some of the let's call it, this is the narrative that can only be shared with someone who's suffering from the same thing. And obviously I've done a lot of thinking about this and wondered why one can't put an end to the affliction. But as we know, that's when the art comes into the science. There are a lot of potential interventions, but why I call it an art rather than the science is what works for Jane doesn't work for Joe. And that's really the bottom line. It is a tailor-made intervention, and everyone is very, very different, both in terms of the dosage that they require, as well as what they need to mix and match. And so in terms of the actual intervention on the drug medication, on the drug intervention side, as I said, there's a lot of potential help. And we look at them in different ways. The first thing we need to know is how many migraines is a person getting? In other words, is this several times a week? Is it once a week? Is it once a month? Is it once in 3 months? Because the frequency is very important in determining how much medication we need to use. Because at the end of the day, we want to apply what we would call the minimal interventional dose, the minimum effective dose, because none of us really want to take more medication than we really have to. So if it's someone who is only getting occasional migraine attacks, then we'd rather treat those attacks. And that may be one a month. And we'd rather just treat that with whatever works for that particular person. And we'll go through that list. If it's someone who's getting frequent attacks, then we need to look at preventative measures, prophylactic measures. And the prophylactic measures there are many types, and they're very different types of drugs. One of the old faithfuls is one of the beta blockers, which is Inderal, propranolol, and Inderal in varying dosages and in different types. So we have all the way from 10 milligram, 20 milligram to the slow release type of Inderals. And in many cases, the Inderal is usually the lasting solution and has been for many years. Another interesting medication which works, and for some reason, in my experience, works much better in women than it does in men, not only because obviously there's a lot more women than men getting migraines, but definitely if one had to bring it down to the percentage of success, then trepoline or amitriptyline, which is an old tricyclic antidepressant, works very well as a prophylactic measure. And this is taken at night. Obviously, its one effect is to put you to sleep, so you're not going to take it at the beginning of the day. It's usually taken at the end of the day. And it's usually taken either as a 10 milligram preparation or a 25 milligram preparation, or more if needed, but strictly under supervision once one gets to much higher doses. And one might be taking both of those, trepoline and Inderal at the same time. Another group of medications that have more recently been shown, or recently mean relatively, they've been going for a long time, but relative to the Inderal and the trepoline, are the anti-epileptics. And the most common one that we use specifically in regard to migraine is Topamax. I don't know if you call it Topamax in Ireland, but Topamax is one of the better of the anti-epileptic stroke anti-migraine medications. The reason why the anti-epileptics came on board was because those that get the atypical migraine have what's called spreading depression. And what spreading depression is a slow wave of electrical discharge across parts of the brain. And it's usually across the visual cortex, causing what's called scintillating scotometer, which is the flashing lights, which goes across and causes the next group of cells to discharge. And so you get a wave of discharge across the cortex. And that was one of the prompts, the earlier prompts to consider using an anti-epileptic, which also had anti-migraine qualities. And Topamax was one of those, and then to a lesser extent, Epilim. And again, I'm not sure what you call it there, but it's Epilim here, which is a lot lower down on the efficacious level, but it is the second one and used for similar reasons. And even though it was originally prompted to be used because of the spreading depression and the electrical discharge, hence the anti-epileptic consideration, Topamax is also very effectively used for the migraine in those who are not having the atypical migraine manifestations. So these two add to the to our armamentarium of our armory of potential prophylactic measures. Then we come to the more acute management. So this is being taken in the background, and assuming you still have breakthrough migraines, then obviously we need to attend to the migraines if they do break through. And by far the most popular intervention, well, in fact, they're very close. The two close ones are the Tryptans and the anti-inflammatories. So the Tryptans, of which there are several, the most commonly known ones are Magsalt, Imigran, which obviously have their own names as well, Zomig, etc. The big advantage for us with Zomig and with Magsalt is that you can dissolve them under your tongue, because one of our big problems has always been to get your timing right, because you need to really get in when that migraine is in its prodromal phase and before it lets rip in a blinder. You've got to get your medication in and absorbed. And often you may have eaten something and you're not going to get the full benefits of your medication. And the big win has been the wafer, because obviously you can absorb it from under your tongue and get the benefits of the full dosage, which has taken out that variable of getting your timing right regarding your digestive tract. And so the Tryptans really came on stream, and they were prompted, their development was prompted by that precipitous drop in serotonin, because at the end of the day, the Tryptans work by giving a real punch to the neurology and to the vasculature to try and prevent that massive overdilatation of the blood vessels, which then precedes that severe migraine component. So the Tryptans have been very effective. And again, it's always fascinating for me to find that certain people will have almost no discernible response to one of the Tryptans and have this incredible response to another one, yet they're of the same chemical family, and yet have such different responses. But therein lies the reality in migraine, that things just don't work universally in the same way for everybody. So the Tryptans are very effective, and they were one of the big, how should I call it? It was almost revolutionary development in the world of migraine, because it took the place, it supplanted the ergotamines, which we used to use to cause the vasoconstriction. They cause severe vasoconstriction. But they had many side effects. The ergotamines had many side effects. And in time, we showed, in fact, on long-term use, there was some very, very serious side effects over long-term use, which was the development of fibrosis in the heart, and in fact, in the retroperitoneal area, which was a very serious long-term adverse reaction after many, many years of use. So we don't really need to use them anymore now that we have the Tryptans. And then there are the anti-inflammatories, which then work on that inflammatory component. But again, not everyone has a very strong inflammatory component, and therefore anti-inflammatories may not be that effective. The anti-inflammatories are very effective in those that have a strong inflammatory component. And in those particular individuals, the results are very good. There's just one problem which I need to mention at this point in time, specifically as regards the triptans and the anti-inflammatories, and that is the rebound phenomenon. The rebound phenomenon is a really, really annoying, and it is a very significant concern. And to this day, we don't really have a solution, and that is we can effectively knock out the migraine with a triptan. We can effectively neutralize the migraine with an anti-inflammatory. But when both those medications wear off, we will get a rebound. Some neurologists have referred to the rebound as actually being caused by the medication. But I can honestly and truly say that I really have tested this and researched this over the years. I could go through a migraine phase and have recurring migraines. I'd have a 12-hour period free of migraine after a triptan or after an anti-inflammatory, and then 12 hours later, I could feel the beginnings of a new one starting again, and I would take the medication again. But after the 5th recurrence, it's gone, and it could be gone now for 2 weeks, 2 or 3 weeks. And for me, that was clear evidence that it wasn't the medication that was actually causing the rebound. It was a severe migraine setting with this overdilated vasculature, which was being held for short periods of time, for the length of time that the medication could hold it, until it wore off and it was still there. It didn't cause the rebound. The rebound was just the prevailing pathology that wasn't held indefinitely. Because after I was through that migraine period of, say, 4 or 5 days, that migraine was gone. There was no rebound after that. And I could test it by, if I coughed or sneezed during that period, I had that tenderness, the vasculature tenderness, and yet after that 5th day, I would wake up in the morning, cough or whatever, and feel no tenderness and know that I'm now beyond the migraine phase and would then have my migraine-free period. So those are the triptans. I've had no personal experience with the monoclonal antibodies. I don't know if my colleagues in town have. I personally have not been involved and therefore can't comment. I know from my colleagues in the States that I correspond with that they're getting an as good response as they are with the triptans, and possibly much more long lasting. So it seems to be a very effective new development, and one that ultimately I will have to explore. Just some other very important aspects, and that is one needs to be aware that there are certain medications which can precipitate or aggravate migraine. And one of those that's very, very common, sadly becoming more common based on its overusage, are the opioids. The morphine opioids tend to cause vasodilatation. And so there are certain migraineurs who are particularly sensitive to the opioids, and it can precipitate very severe migraine, and those are very, very difficult to treat. I had one particular case of a severe brittle migraineur who underwent a cervical procedure, a cervical vertebral procedure. I did a discectomy on him, which went uneventfully. He was a chap in his late 40s, uneventful, a very, very brittle migraineur who really was, I was battling to control him with a combination of triptan, Indirol, trepoline. We were really on mega treatment. And on occasions, he was having to take injectables. He was having to inject Immigrant from time to time. So a really difficult migraineur, but managed to keep things well. We did this procedure, and for some reason, this slipped through the anesthetist prescribed morphine as small doses for intravenous microdosage after the procedure. And when I finished my surgical list, I was called to the high care unit to see him and to ask me to come quite urgently. We were in a lot of trouble. And I was very worried. I thought something had gone wrong from the procedure. I had done a neck procedure on him, only to find him literally screaming and clutching his head with this newly precipitated migraine from the morphine microdosage intravenously. And it actually took us 5 days in intensive care to actually get control again over the migraine. So just a warning that the opioids in susceptible individuals can precipitate a severe migraine. And we need to be aware of these, and they can be found in many, many medications. Just something I'll share with you, because it just becomes very fortuitous that I can share this with you, because it illustrates a similar situation that happened to me. So a week ago, I had to have surgery. It wasn't major surgery. I had to have sinus surgery. And I've had anesthetics before. This has never been a problem. But when I was descending into anesthesia, I noted just for those short few seconds that this was a totally different anesthetic emergence. And I obviously fell asleep and woke up afterwards, feeling a little strangish. But to cut a long story short, I then developed rolling migraines and atypical rolling migraines on a daily basis for a week. It ended 2 days ago. For a week, I had both atypical flashing lights, spreading depression on the right, then spreading depression on the left, 2 or 3 times a day, and then blinders. Just could not work out what was going on. I'd really lost complete control over the migraines. Spoke to the anesthetist that actually gave the anesthetic and said, I'm just interested to know what medication you've used, because I've never had this result before, this consequence before. And what she had used, which is atypical, it's not used commonly, was an anesthetic drug, which was what we call an alpha-2 blocker. In other words, it blocked the alpha receptors in the blood vessels and caused this massive vasodilatation. So it actually precipitated this vasodilatation with a very high dosage, which took most of the week to metabolize out of my system. So just something also to be very aware of. And I unfortunately don't have the name of that anesthetic agent, but I'm sure your anesthetist will be very familiar with it. It's a well-known drug, not as well used or as commonly used as the others, but it is one of the alpha-2 blockers. And once you say alpha-2 blocker, they'll know exactly which one you mean. That should not be used with a migraineur. And I know it now. In fact, I know it very well to my detriment. So that's very important. So the drug interactions are very important, and we need to be aware of these, because often we'll end up chasing our tail. So for example, you have a drug, an opioid, which is called Travidal, which comes in many different forms, and it has different combinations, and you can combine it with paracetamol and get what we call here Tramacet, and I'm sure it's got similar names. But again, the migraineurs don't do well with that Tramabit. The Tramabit is an opioid, which will predispose to dilatation of the blood vessels and can precipitate the whole migraine process again. So that's really the overview that I wanted to share. There are some other drugs which are used a lot less commonly. So one of the drugs we use for cluster migraine, cluster headache, is verapamil. Verapamil can be used as well on a daily dose or on a slow release basis, and it does work for certain people, not for everybody. So verapamil is something to also consider. And then there's the benzodiazepines, much, much lower on the list, the Xanors and what used to be Valium. I also use, this is much, much lower down on the list from those that I've already mentioned. Obviously, we have limitations on the use of anti-inflammatories, both in terms of the stomach and in terms of kidney function. And that is the silent killer, is that kidney failure. We don't know it until it's symptomatic, or unless you're testing your bloods routinely. And you'll be amazed how damaging long-term anti-inflammatory usage can be. Because in fact, we don't talk about how many anti-inflammatories you've used in the day, in the week, in the month. We talk about how many anti-inflammatories you've used over 10 years, because that is the figure that affects kidney function. And over years, that can amount to several thousand. And that's the kind of insult that you could have brought to bear on your kidney. So be very careful with the liberal use of anti-inflammatories that can be very damaging over a long period of time. So that really is the essence of the subject of migraine, complicated. And yes, diet is very important on the lifestyle side of things. They are the classical ones. A very high percentage of classical migraines are very sensitive to alcohol. Alcohol can precipitate the vasodilatation. And then there are the strong cheeses and the chocolates, those which are well known. Again, not to everybody and not the full list. Again, it's very specific for individuals. And there's a long list, obviously, that one has to be aware of at least, which might be precipitating or aggravating one's clinical situation. So we say, obviously, the lifestyle would apply both now to sleep, to diet, and obviously you need to be very aware of your blood pressure. The silent background precipitator being hypertension that you're not aware of. Those morning headaches are not just migraine, those morning headaches could well be the beginning of hypertension, high blood pressure, which is a potent stimulant of migraine.